Good morning, good afternoon, good evening, wherever you are logging on from. Welcome to the November issue of the Australasian Pleural Seminars. Today we're going to have an important and practical topic that is not well written in textbooks, and that is how to look after chest drains and indwelling pleural catheters and how to troubleshoot. So it's my pleasure today to introduce Chloe Charlesworth, who is our pleural nurse specialist, and with many years of experience in looking after inpatient and outpatient management of pleural drains and pleural diseases. So she's going to talk to us about practical tips on pleural catheter care for doctors, what doctors need to know. And as always, please type in your questions in chat, and we'll go through them towards the end. So we'll hand it over to Chloe now.
Yeah, thank you very much, Gary. Welcome, everyone. So I'm going to be talking today on the most common through to the most uncommon complications that myself as a pleural nurse I see every day. I've broken the talk down into two sections, intercostal catheters and indwelling pleural catheters, but I do recognise that throughout there will be principles or particular problems that relate to both of them, not individual to one or another. So first of all, I really want to bring it back to the basics, to dressing and handling. We go to all this effort to put these chest drains in, and while a suture is gold standard to keeping it there, a really good dressing is just as important. So these images here you see, they cover both indwelling pleural catheters and an ICC down the bottom as well too. And we really want to think about the core principles. Every place will have different dressing equipment available to them. So you've got to work with what you've got, but we want to understand the three core components. So first of all, that's some padding to the skin to protect the skin itself from the drain, but also to prevent any kinking or blockages. And generally that's a fenestrated foam type dressing. Then we use some gauze, and that protects, again, the skin, but more so the tube itself, again, from any kinking, from any significant tape adhering to it. And we generally use some gauze for that. And then finally, we have our clear, occlusive, waterproof dressing. So again, stops any contaminants from getting in, but we can also still see and visualize the insertion site if we need to assess the surrounding skin or for any complications. There'll be plenty of guidelines out there for you as to how to do this and how best to do this. So the examples I've used in these have come from the British Thoracic Society and also from New South Wales, but you'll have your own hospital clinical guidelines. There'll be manufacturers' instructions, and there's plenty of video instructions online as well too. So it's really important that we get these basics right and do a good dressing, because there's definitely a not so good dressing. So we can see here just the excessive tape. And what I'm about to go through now are some examples of complications that can happen that could be directly prevented by a good dressing. So these are all examples of kinked or twisted or blocked tubes that we've experienced here at Sir Charles Gairdner Hospital. So we can see on the first one, that's quite a mobile patient who's managed to get a very impressive twist and blockage in their tube. The next two are a little bit more subtle. So both of these are small bore tubes, and both of the kinks were actually hidden underneath the dressing and weren't visualized. So for all of these cases, with some slight changes and anchoring and adherence with that dressing, we probably could have avoided these kinks and these blockages. We move on then to some other complications that we can see as well too, and that's dislodgement and pressure injuries. So I'm really quite proud of our team in that they've taken on a very proactive stance to helping to minimise these. And they really lead by examples, not necessarily waiting for the nurses to come on and do these extra bits and bobs when they identify or once it becomes a problem, but straight from the bat, as soon as that chest tube gets put in, we're taking these actions to help prevent these problems. So in the first picture you can see there, although there's a good tape anchor, that connection has still managed to become disconnected. So again, changing where we place our tape and how we place that tape could potentially have avoided this. And the same thing with the picture on the other side, we can see that there's a significant indentation in the patient's skin from where the hard plastic has been sitting. So what our team have taken to doing is putting in a prophylactic soft dressing underneath that three-way tap to prevent that pressure sore from happening in the first place. So moving on to probably the most common dressing complication that we see, and that's an allergic reaction to the dressing material. Now you will see these with ICCs, and we do see them quite frequently with IPCs, more so because the dressing is on for a much longer time, given the duration that the IPC stays inside for the patient. But what's most important, regardless of what type of drain they have, is that once we identify the problem, we need to make sure that we prevent any further breakdown. And this will take an individualized approach into how we manage this. So we can see in this photo, the patient has some classical signs. They've got redness, they've got swelling in their skin. It follows quite obviously the shape of where the dressing was sitting on the skin. And if we look a bit closer still, we can see that their skin has started to blister. So this is evidence of quite a significant reaction. And if these blisters break, and I've had patients say to me before that if they break, the pain they get from that is more significant than any discomfort that they actually got from the tube going in the first place. So we want to try and avoid that, or at least minimize those symptoms if we can for patients. So how to tell if it's a reaction? We want to look for the telltale signs. So we can see in these cases, the rash or the vesicles, they all follow the contour of the dressing. So it's got quite that rectangular obvious shape, almost like a photo frame around the chest drain. And we can see with that patient on the left, they've also started to blister a little bit there too. And we want to make sure that we recognize it for what it is, that not all redness necessarily means that it's an infection in the patient's skin. A good gauge to use is if an itch is also present. That often means that it's an allergy. And I also just want to note, I've got redness there in quotations because not all patients will show redness as their dressing reaction. We can see this patient in the middle who has a darker skin tone. They still have a dressing reaction, but not necessarily any redness there, but they have a definite change in their skin color there where the dressing is reacting. So how do we manage this? So quite simply, we need to change the type or the form of dressing that we're using. This will be different for every single person. It can take a lot of trial and error until you find the right dressing that works for them, with patients quite often being allergic to multiple different types. You also have to work within the limitations of what dressings you have available to yourself in your department. Regardless of what you change it to, the most important thing is that you avoid contact with any already broken down areas. If we continue to replace dressings onto those, the areas will continue to break down. So I've given some general examples here of different types of dressings that can be used, and some of these you might have available, some you might not. And potentially, and I'd say very much the exception to the rule in extreme circumstances, we have had a couple of patients in the past who've eventually gotten down to no dressing at all. This wouldn't be appropriate for every single patient, but for those that it is appropriate for, we just ensure extra additional cleaning, and we make sure that they take extra safety measures like wearing a tight singlet or something like that to help prevent any dislodgement of the tube. But for those patients, we've had great success in that they stop having a dressing reaction, but there's no necessarily increased risk of infection with those patients either. But definitely the exception to the rule. That would take a lot of trial and error before we got to that point. So in some really difficult cases, when patients are quite symptomatic, very itchy, uncomfortable with their dressing reaction, we will look at putting in some extra strategies. So that could be oral antihistamines or a topical steroid cream as well to help manage that. All right, so moving on to the next complication that we see, and this is a little less common, but it's the rapid drainage of pleural effusions that can result in re-expansion pulmonary edema. So the typical signs and symptoms of this is a patient who displays shoulder tip pain. They have a cough that's almost involuntary, quite dry. They might experience a sudden drop in their blood pressure or oxygen saturations and an increase in their respiratory rate and distress. So I'm going to give an example now of a patient and their x-ray who experienced this. So we can see this patient here has a very large left pleural effusion. We come along, we put a chest drain in for this patient, and then, as it almost always is, they had an accidental over rapid drainage of their fluid and lost about 2 litres in a short space of time. So looking at their post-chest x-ray, we can see that the effusion looks much better on this x-ray now, but they now have a new process, and we can see that re-expansion pulmonary edema occurring there. And this is really quite distressing for the patient as well too. So how can we avoid it? So ideally, large effusion should be drained incrementally with no more than 1.5 litres in the first hour, but you could even look at reducing this amount to say 1 litre or 500, depending on your patient's condition if you're wanting to be really cautious. To help manage this, you want to have really clearly documented instructions for your nurses, and that includes the maximum hourly drainage rate that you want drained, but also when they should stop. So for example, if the patient does start to display any of those signs or symptoms, the discomfort, the persistent cough, any vasovagal symptoms, they know that that's a warning sign or a red flag, and they should stop the drainage there and seek assistance. I also like to stress the importance of patient supervision during potentially riskier times when accidental overdrainage can occur. So that's in initial position changes or standing soon after the chest drain's been inserted, times like toileting where the patient or the nurse might be distracted from the chest drain and what's going on, but even things like chest x-ray. It could be the first time in the morning the patient stood up, or the first time in quite a few hours the patient stood, and then an accidental overdrainage can occur then. All right, so I'm going to move on now to indwelling pleural catheters. They're silicone tubes that have a profibrotic cuff that's tunneled subcutaneously, and they allow patients to drain their recurrent pleural effusions in the comfort of their own home. There are many different brands out there. For today, I've really only focused on the two that I see most commonly within Western Australia, but I do recognise that there are other brands out there as well too, and those might be the ones that you're more familiar with. But regardless, the problems that are incurred by IPCs or patients with IPCs are common to all manufacturers. So first of all, I want to look at the clinical decision treatment making. So I'm not going to cover drainage regime today, daily versus symptomatic, but if you do want more information on that, you can see the previous studies our team have done, so that's ample too. But what I do want to talk a little bit more about is the device choice, choosing a bag versus choosing a bottle. In some places, this will purely come down to logistics. What have you got available to give to your patients? But in some places, if you have the option, we can toss up what might be the better option for the patient. Sometimes that comes down to cost. The bag is potentially a bit cheaper, but the bottle can be a little bit faster and get the drainage done quicker for the patient, but it can also incur pain. I like to give a bit of control back to the patient. So regardless of what device they're using, the bag or the bottle, I like to make sure that they're comfortable and have some elements to know how to manage that best. So for example, with the bottle, we know that it can cause a bit more pain, but there may be patients who have small fibrin clots or trapped lung and they need to use the bottle to help draw their fluid out. It might not necessarily come out by gravity. So I do that by allowing the patient to know that they can take the controls, whether that's the roller clamp on the bag or the button on the bottle, and they can use that to start and stop the drainage the second that they get any discomfort. So they don't have to wait, they don't have to be anxious in the lead up to their drainage, that might be something that they're going to experience. They've got control, they know when to stop, and they know that they can say to the nurse, no, that's enough, no more, thank you. And I think that's really important for them to have. So moving on now to the more uncommon complications that we see, but nonetheless very important. So with all IPCs, they have a safety feature. So when the cap is off or before the drainage line is connected in, or vice versa, that time when there is nothing on the end of the valve, they have a safety feature of a one-way valve. So no air can be entrained and no fluid can leak out. But as with any medical device with overuse or misuse, that can become faulty or damaged. So I'm going to show you a video in a moment of one of our patients, and it shows a faulty valve. And I just want you to look closely at what's happening in the fluid leaking out. So it's quite subtle. It's not always easily picked up. So it's one of those things that you do learn with experience, but it is easily manageable. So for all manufacturers, they make an IPC valve replacement kit. So when you identify that there is a faulty valve in the system, it can be managed and changed quite quickly. And it comes with the whole set, everything that you need: the new valve, a clamp, some scissors, and some dressings. It's really important that if you, one, identifying the problem first and foremost, and then two, if you identify the problem, you know that it can be fixed. If you haven't changed this before, I'd really recommend getting a senior member of staff to come and assist you with this. So what I want to show you in the next video is a before and after. So as I mentioned before, with that safety feature in the IPC, the one-way valve, it shouldn't be letting any fluid leak out like you saw in the video before. And it shouldn't be letting any air up and into the system. So the next patient case study I'm going to show you is a patient who had quite a significant trapped lung. And this issue of the faulty valve was identified when the patient came into our clinic, but it's likely that there were probably some issues happening in the community before he came into us. So I just want you to watch closely in this video the before and after. So in the before, you can see quite a significant movement of fluid, and then just have a close look at what happens after we replace the valve. So we can see that movement, the patient had quite a significant trapped lung, hence why the air was pulled in as opposed to leaking out. And after, we see nothing. So that's exactly what we want to see in a good working valve. So really important. That's a great change, and we help prevent any future problems or complications that could occur from a leaky valve for that patient. So on to the final one, and this is the most uncommon complication that we see, and this is a leak in the system, so with the actual tubing of the IPC. So this is a case study of a patient of ours. They were in a regional hospital in Western Australia. They had an IPC for their malignant pleural effusion, and in the process of removing the dressing from around the IPC, and this goes back to our basics at the start of this presentation where we spoke about why it's so important to do a good dressing, not only for the comfort of the patient's skin, but also for the protection of the tube itself. So in this case, unfortunately, there was a bit too much tape stuck onto the tube, and in the process of removing that with scissors, it was unfortunately cut and it sustained a few lacerations. So we're in a bit of a pickle here. This patient, they are quite end stage in their disease. Removing the IPC and putting in a new one is not necessarily in their best interest, but they still needed an IPC as they were still having a recurrence of their pleural effusion that needed to be drained. So we brought them down to our tertiary hospital, which isn't a small feat. It's still about 4 hours drive away from where the patient was to where they had to come to us. And we did some tests. So in the next video, I'm going to show you, we've got the drain clamp, and those are the small lacerations there that you can see, which are a little bit difficult to visualize. But you'll see them much more closely in the next video. So we clamped the tube quite close to the patient's skin, and then we flushed the saline. So you're going to be able to visualize exactly where those lacerations are and how close to the skin they are as well too. So quite a complicating factor. So what did we do? Well, we were able to use the IPC replacement valves that I showed you in the previous slide, and we were able to actually cut the tube below the lacerations and insert a new valve. So the patient was able to keep their IPC and they're able to keep their drainages, then eventually go back home to their regional country hospital as well too, to continue their care there closer to their family. So overall, I just want to reiterate that clinicians and nurses, we really need to be aware of the subtle but significant complications that can happen for pleural catheters. And we need to make sure that the utmost care is taken with these pleural catheters, because even small or minor damage can have a really serious consequence for our patient. And that's it. Thank you.
Oh, great. Thank you. Sorry, I was muted. I think I'll just encourage everybody to come and type in any questions you have got. But in the meantime, I'll start first. So you deal with the community problem troubleshooting quite a lot. So what are in your experience, what are the most common questions that you usually faces on a everyday journey?
Yeah, that's a great question. Our community nurses are really good. And I think having a direct link in them being able to call me as soon as they identify a problem has been great for our patients' care as well, and identifying problems early. In simplest of terms, probably breaking it into two parts. The pleural catheter, or the IPC itself, the biggest concern or problem that they would call up about is a reduction in fluid output. So we'll often take the time just to do an assessment with the patient over the phone and see, are they feeling symptomatic with that? So the nurses might call up and say, patient so-and-so has had only a very small amount come out, or none at all, potentially. And so we'll assess that patient. Are they symptomatic with that? Are they breathless? Do they have a cough? Do they feel like that fluid's reaccumulating? And then we can make some plans from that. I'll often use a bit of my background knowledge of that patient, so knowing what their latest chest x-ray or ultrasound look like as well, and what their condition is. Do they have any underlying things? Do we expect there to be a loculation, infection, or clots? And then we can use that to make a plan together. And sometimes that plan might be, yep, we expect that this has been a gradual reduction in fluid. Their last ultrasound or x-ray was looking really good. We don't need to make any changes, any plans to their care. We can continue on as is. In other cases, it might be that, oh, this patient actually drained 400 mils only a few days ago, and now all of a sudden they've got nothing. Something's going on here. So in those cases, if they have if we need to, we can manage it in the community. So if they used a bag before, we might say, let's trial a bottle, see if we get any difference from that. Otherwise, we have the option to bring the patient into clinic and we can troubleshoot a bit more closely there if they have any blockages in the tubing that we need to clear, or otherwise we can do that. The other thing I'd say that I get the most calls about is probably patients' blood pressures as well too. So often they'll give us a call and say, patients' blood pressure is low. Is it safe for us to continue this drainage? And I'd say for the most part, yes, we generally encourage the drainage to continue. Generally, we don't see a significant drop in a patient's blood pressure when they have a pleural fluid drainage. And for the most part, they're smaller amounts as well, to a few hundred mils. Of course, there will be some patients who drain a lot more and who do get symptomatic with their drainages. And for those, we'd probably manage them a bit differently. But for your standard patient who's maybe just got a slightly lower than normal blood pressure, and again, we'd do a symptomatic review. Are they dizzy? Are they lightheaded? Have they had any medications that could be impacting it? But if there's no concerns from that way, generally we'll say, yes, continue with that drainage. You can call us back if you do have any concerns or problems afterwards. And then we'll close that loop by making sure that we send through modifications as well, so that the nurses who go out in future know that, okay, I know it's safe for me to continue, do this drainage, the patient's safe with a slightly lower blood pressure for me to go ahead. So those would be the two main things that I get calls from the community nurses for.
Great. Got one of the online questions. What is the best way you would recommend to secure small bore Salvina tubes to prevent kinking or twisting?
Yeah, great question. So obviously going back to the pictures that I used of the dressing, so think of our core components, some foam that provides padding to the skin, but also a little bolster underneath the tube as well too, so it's not compressed completely down onto the skin where it could kink. But once you've got your foam, a little bit of gauze for extra bolster or padding, and then your clear occlusive, often that secures it quite well, but it's all the tube outside of the dressing that can then become a problem, like you saw in that very first photo with our mobile patient who'd managed to twist their tube multiple times. So for that, I'd recommend an anchor. So a securing anchor with a strong fabric tape. But there are some adjustments you can make to this to make it work better for you. So don't just stick it straight onto the skin and have the tube in direct contact with the skin. Do what we call an ornamental or an anchor securing tape. And apologies, I can't describe this quite well online, but essentially want to have the tape on the patient's skin, the tape touching together underneath the tube and then around the tube. So the ICC itself, what's outside of the dressing and further down, going down towards your underwater seal bottle, is stuck together and held together quite well, but not actually in direct contact with the patient's skin. So that's a really good one that can hold it in place. So that's an ornamental or an anchor securing tape. And then, as I mentioned before as well too, just little adjuncts like putting a soft padded dressing underneath your three-way tap. And then sometimes we'll even secure it again with another anchor dressing there, or a mental anchor dressing there, so that it can't move away, because there's no point in putting a nice soft dressing in one place and then the hard plastic sits in a completely different other place.
Yeah, and I think to add to that, check your drains on a daily basis. Don't be shy to take down the dressing, otherwise you can't see a lot of this twisting and of the tubes. And a lot of the Saldinger drains, they might actually have a colored line that runs down the tube, so you can actually see if it is twisted. Without that color line, sometimes it is difficult to notice that it is. Right, next question. How often would you recommend the ward patients to have their chest drain dressings changed?
Yeah, so for ICCs, so the short-term intercostal catheters, we use a general rule of thumb that if it's a small bore drain, we do the dressing every 48 hours. And if it's a large bore drain, we do it every 24 hours. With the caveat, you can also do it PRN. So if the patient leaks through their dressing and you need to replace it the same day, then obviously do that as well too. For the IPCs, our general rule of thumb is if it's a brand new IPC, you do the dressing in 24 hours. And then after that, it used to be once a week, but I will say that with the introduction of Ample4, we have been doing it a little bit more frequently as well too. So I often recommend a minimum twice a week for patients. And that also takes into account patients who the dressing just doesn't last that whole week if they're maybe a little bit sweatier or moving a little bit more as well too.
I think there's a question of dressing for large bore tubes, but I think you have pretty much just answered it. You mentioned about leakage, and that's probably what the junior staff often get called, that there were, chest drains, be it large bore or small bore, and then there's wetness around all the dressings. So what do you usually advise?
Yeah, so for intercostal catheters that are leaking, I think first and I like to do, whenever I do my assessment of a patient or if I'm talking to the nurses, I'll say do your chest chamber. So the first thing you want to be looking at is the patient themselves and then their chest as well too. So you're assessing, is that dressing dry? Is it intact first and foremost? So if it is leaking, what kind of leaking is it? Is it pleural fluid? So does it have the same consistency as the fluid, or is it blood? Because you'll manage those quite differently depending on what your answer is. For today, I'll just talk about if it's leaking pleural fluid. So if that is the case, then we need to consider a few things and start doing some troubleshooting. So first and foremost, we can reinforce our dressing, but importantly, reinforcing it around the ICC exit site, because sometimes it's just a path of least resistance and it's allowed to leak through. So we can do that by using some jelly impregnated dressing. So Gelinet is one brand of that, and we can twist it around the actual tube site and help it act as a bit of a plug in that case, while then also using our foam, our gauze, and our clear occlusive to help keep that blocked. If that doesn't work, then we need to have a look at, okay, why is this leaking? Have we got a blockage in our tube and the fluid's trying to come out, but it can't? So maybe giving our chest tube a flush to make sure that it's patent, that it's working, and help allow that fluid a way to come out. Because if our chest tube is in, it should essentially be coming out through that. So just doing those little features to check. Those would probably be the biggest things for leakage. The other thing to consider is fluid that could be leaking but not actually finding an exit site. So it doesn't happen very often, but you can definitely have patients who start to develop swelling of the skin around the ICC. That's not necessarily discolored skin or bruised or bleeding, but definitely an obvious swelling point. And that we need to be careful of as well too. Same problems. Could the tube be leaking? Are we allowing fluid to leak into another area? So just being cautious of that and then managing that as well. Pressure dressings, potentially even having the patient lay on their alternative slide so gravity can work in our favor and keep the fluid down until we can get that leak under control so they don't continue to leak into that space. So those would be the most common ones I see. Sometimes when we remove the tube as well, so post removal, we can see a bit of leakage. Again, same things. If it's a small amount, we can manage it with changing our dressing, reinforcing that hole, maybe a suture if needed. In really extreme cases, we might look at putting a wound drainage bag over the top as well. Again, just to allow whatever leftover fluid is in there to come out, but still keeping that area covered so it's sterile and we're not going to allow any bugs to be introduced. And once that fluid output is settled down, then we can look at, can we stitch this now? Can we redress it now?
Yeah, excellent. Maybe the final question. So a lot of places at the moment does not necessarily have community support for the patients, and so they relies on their carers to do the drainages. What sort of protocol or what kind of education do you usually take with the carers before you allow them to go in the community to do the IPC drainages?
Yeah, great question. So I like to, first of all, although we are giving them a lot of responsibility, I like to let them know that they're not alone, that they will always have our backup and support as well too. So not to feel like they've just been given this huge responsibility that they're in charge of now, that will always be here for them. So we start with the basics. We get them to come in and we get them to watch one of the nurses doing the draining, doing the dressing. Then we get them, when they're ready to do so, to do it themselves, but with direct supervision. So with the nurse who's also scrubbed up and will help them through that process step by step. They can ask questions. If they make mistakes, that's okay. We just readjust. We've got more equipment to make sure that it's all done in the correct sterile way. For some patients, for some patients' carers, they might pick it up very quickly and need only a few sessions. For others, it might take a bit longer. For a few, we've even had to make a couple of adjustments as well. So for example, we had a patient whose wife could do the most part of the dressing, but because of her arthritis, she did just struggle a little bit with the dressing at the end. So we changed it up and had the patient assist in ways that they could as well too, while still maintaining sterility of the dressing. So we made it work for them and they were both comfortable and they were able to do that together. Once we've had the patient go through doing it with the nurse under supervision, then we get them to do them themselves without any sort of direct input from the nurses. And then once they feel 100% confident and comfortable, and once we're confident and comfortable that they've been able to do the whole dressing, the whole drainage, maintain sterility the whole time, then we will provide them with the equipment and let them go home. We are quite lucky here in that we have nurses who can visit and who can also know IPCs really well and check on them in the home. But I think even if you don't have that, we have other avenues now. So they could do a video call in the home. And this is something that we do quite often with our patients who live in regional areas quite far away. If they, and we still do now as well, not only just at the start, but at any time during that process, if they run into any troubles or questions, we'll just do a video call for them. So I can see them, they can see me, but more importantly, I can see exactly what they're doing and what the problem is, and we can work through and troubleshoot that together. And then making sure that they have all the equipment available as well too. If they're running low, we make sure that we have it, but also making sure that they know to come to us for any problems. I don't want to put the responsibility of troubleshooting any problems on them for them to sort out by themselves. It's very clear that any problems, and we make sure they know what the problems are to look out for. So everything I've spoken about today, dressing reaction, valve problems, leaking, that they know that that is an issue and that they need to call us for it. But it generally works really well. And I think I find that the patients who have a carer that can do it, they really appreciate the convenience of being able to do it whenever they want, the consistency of someone who knows them and knows them really well and can easily identify any changes, but also they can travel, they can go places, they can see family, they're not tied down because of the tube. So it's quite beneficial for them in other ways too.
Okay. This will be a very quick one. This is your last minute question to say, should we squeeze the IPC each time we actually look at the patient? I think we don't need to do that. It's just only if you're saying that there's any leaking at the present. Okay. So, any other final comments from you, Chloe, before we finish?
No, just thank you very much for the opportunity to do this. And I really appreciate being able to get this knowledge out there. And I greatly appreciate our community nurses as well too. And I think that it's all great us learning this, but if we can disseminate and pass that knowledge on to others, then it can help us in our care of these patients too.
Yeah. So thank you very much for all those who attended today. Next month in December, we will have Dr. Carolyn McIntyre to talk about another very common question that the patients ask us. How is exercise going to benefit us if in the patients with malignant pleural effusion? So we look forward to seeing you then. Thank you very much for joining us today.
Thank you.